Very good morning to all of you. I'm Babita working with Sangath team Bhopal. Thank you so much for joining in our monthly research seminar series. So today's discussion topic is use of health economics studies in policy decisions. Just to also mention that we plan to record today's session and also upload in our social media channels like Facebook, YouTube, etc. Speaker is comfortable with that. The session will also be moderated by me and my colleague Shivangi. So feel free to ask questions on the chat window. At the end of the speaker's remarks, you will also have a chance to speak questions through the speakers. You can unmute yourself and ask the questions. So the plan is to speaker to speak 40 to 45 minutes and rest of the time available for the discussion. So now I'm coming to the speakers and the topic. As I earlier said, today's topic is use of health economic studies in policy decisions. So thank you, Dr. Susmita, for accepting to speak in Sangath's monthly research seminar. Dr. Susmita Chaterjee is a senior health economist at the George Institute for Global Health, India. She has a PhD from the University of Calcutta and is interested in investing costing of health services, health financing, and economic evaluations. She was worked on several health economics projects in the area of mental health, diabetes, cholera, typhoid, tuberculosis, and immunization. She was the recipient of Asia Fellows Award in 2008, Indo-US Public Health Fellowships in 2013, and Wellcome Trust DBT India Alliance Intermediate Fellowship in Clinical and Public Health in 2017. She was the co-costing working group member for preparing the costing manual on providing payment mechanism and initiative by the Joint Learning Network GLN USA and the economics group member of DB MAC. So thank you very much, Dr. Shishmita, to be here. So over to you, Dr. Shishmita.
Doing several policy applications. So I'll be talking about the study to tell you why we did this study and how it was used. So basically that's the plan of this session. Next, please. Um, Thanks. So my studies, the studies which I'm going to talk today is mainly on immunization. It's not on mental health though, because these study results actually are used. But I just want to give you a background so that, you know, some of you may not be very familiar with the Indian immunization system. Just want to give a background so that you know how this program is, and then I will talk about the study. So basically, the India's immunization program, which the government runs, actually started in 1978. It's long back, and the current form of the program actually started in mid 1980s. So it's about 35, 36 years now, which it is running. It is one of the largest of such a program in the world, because the target children per year is 26 million. It's a huge number of children, those who needs to be vaccinated every year with all primary doses. I'll come back to you what I mean by primary doses, just to give you a clarity. And then we have like 30 million pregnant women in our like target pregnant women every year who needs to get tetanus toxoid vaccination every year. So it's a huge, huge program in running in the country by the government of India. And to reach to these newborn and the pregnant mothers, pregnant women, actually the government organizes a lot of immunization sessions. So approximately 9 million immunization sessions each year are conducted, but this is like 2 years back data, so it should be more than 9 million now. And I'm pretty sure that those who have children in their houses, in their home, you know about the vaccination system, but probably you give vaccination to your kids from a private sector, probably. So there is a role of private sector in vaccination as well, but that is only 10%. In other cases, we see that private sector actually dominates, but in case of immunization, it is like 90% by the government. Next, please. Yeah, so when I said primary doses, again, if some of you must be familiar with this vaccines, which needs to be given to a child in different as per the schedule. So if you are taking the vaccine from the private sector, there could be some other vaccines as well, but this is the government doses which like in schedule, in these vaccines are in government schedule, which the government provides to the children as per their schedule. And you can see there are a lot of vaccines, that there are new vaccines coming up. So so one child needs to get all this vaccine in the scheduled time to get fully immunized. So that's the objective of the program, to reach out to 26 million kids with these vaccines and on the scheduled time, and then the TT vaccine for the pregnant woman. So you can imagine it's a huge program running in the country by the government. Next, please. So when the child gets the vaccine actually from the government sector, again, it is free for the child. Like for the parents and the child, it is free. Only cost that the parents has to bear is the time cost, because they need to bring the child to any government health facility to get her child vaccinated, or it's the travel expenses maybe. But for the government, it is a huge amount of money that needs to be spent to reach to this 26 million baht cohort. So it's a huge amount of money. Now, the government of India, actually, the immunization division, for the first time, they did a planning of immunization. Like before 2013, it was there was no actually concrete plan written down, like how the program will run in next 5 years. 2013 was the first year when the government actually said, okay, there is a plan how the program will move on from 2013 to 2017. And that's the time in 2013 when I got involved with the ministry, with this department, because they wanted also to cost this plan, because it's a, as you can, I'm saying several times that it's a huge program, and to run the program smoothly, they felt that there is a need to have a plan, and they also felt that they need to know what is the current situation in terms of expenditure, what is the current expenditure of the program, and if we move like with this plan in next 5 years, what is the financial implication? How much money do I need in 2013, 2014, 2015, something like that. So that's where for the first time I got involved in this activity, and I was given the responsibility to cost this plan. So when we did the plan, so the one I reported here, the current cost and projected financial needs of Indian immunization program. This is the work we published, like the costing and financing work which we published in IJMR. Actually, when I did this work, I realized that we are making so many assumptions to calculate the cost. You know, the actual expenditure is there, the data was there, actual expenditure for the baseline. But for doing the projection, for doing like to think about what will happen in future, there are a lot of assumptions we put in this calculation, financial projection calculation. And from there, it came in my mind that there is a clear dearth of cost data in this area. Like we don't have any unit cost data to support this exercise, because we definitely, because it is such a big program, we definitely need to make assumptions, but to make the assumptions robust, the results robust, we have to have some concrete assumptions, so that we can say, okay, whatever we are saying, like the financial implication in next 5 years, it's really this is the money we need, because that's the starting of our work, which I'm going to talk about today. Now, how the immunization budget was fixed in other years, like generally how it is fixed is based on previous historic expenditure data. So suppose in 2012 something happened. So if there could be a 5% increase in one head or 10% decrease in one head based on the expenditure of the previous year. Generally, this has happened, and looking at the historical data. There is no cost information to support this kind of analysis. So that's the starting point of our work, which I'm going to talk. Next, please. Yeah, so I have already spoken. We estimated the cost. Actually, the cost we estimated is to understand how much does it cost to the government to provide one dose of vaccination to one child. So that's the very basic question, because I'm spending so much of money. What is the cost actually? Am I spending the right amount, or am I spending more or less, or what is it? So to answer this question, we wanted to estimate the cost to the government to provide immunization to one child. That was the objective of this study. Next, please. Yeah, so basically we wanted, then if I really want to do this, I need to have a representative sample of the state, like of the country. But it is so difficult to get a representative sample for this country, such a huge country. But still we tried. So what we did, all 29 states were divided into different levels of development and as per region. Now, how these levels of development was determined? Of course, it was based on the immunization coverage rate of the states. And then also there are some other indicators like female literacy rate, because we believe that if the females are more literate, the parents, female mothers are more literate, it's more likely that she will get her child vaccinated. Per capita income of the state tells us overall development of the state. IMR also tells us something about the state regarding the maternal and child health, etc. So we took these indicators to put these states into different levels of development and region. Then we picked up one states from each level of development and representing each region. Just for example, Kerala was taken from the most developed and south. Punjab was taken from number 2 level of development and representing north, like this. There are a couple of exceptions. From column 5, level of development, we were supposed to go to Arunachal Pradesh to represent Northeast, but at that time there were some security issues in Arunachal, so we had to choose Meghalaya. And as you can see in the list developed, we have both Uttar Pradesh and Bihar in the list. This is because both Uttar Pradesh and Bihar are the high priority states for the government to improve immunization coverage. So there was a request that we cover both so that we can get the cost estimates for both of the states. So these are the states where we did this study. Next, please. Yeah, so this is like 255 public facilities were covered from 24 districts of 7 states, and the distribution is like this. So postpartum unit is, in the district hospital, postpartum unit were covered, and then community health center, primary health center, and sub center. At each level, we tried to estimate the cost per child, per dose, etc. And in terms of sample size in per state, it was generally 48 for the big states like Gujarat, Punjab, West Bengal. Kerala had 33, Meghalaya 30, and Bihar and Uttar Pradesh, as we took these 2 states from the same level of development, we just divided the sample size 24 each in each state. So total is 255 public facilities covered in this study. Next, please. So very briefly, the costing methodology used, it was economic cost, which was calculated. Now, what is economic cost? There are 2 types of cost. One is financial, one is economic. Financial is basically the financial outlay to conduct a program. It's basically the actual expenditure which you are incurring, but you can calculate more. It's not always your expenditure report will not show all expenditure under one head, but it's so basically it is the money spent. What I'm trying to say for the program is the financial cost. Economic cost is financial plus it takes into account the opportunity cost. What we call in economics is opportunity cost. That is the cost of foregone activity. So we believe that when you are doing something, you cannot do the other thing. Like when I'm presenting today, I'm not doing the other work at my office, right? You cannot do two works simultaneously, and there is a cost associated with that. So my time cost will be calculated to cover this opportunity cost. And economic cost actually takes into account this kind of cost, which is like valuation of volunteer labor, well, time spent of the workers who are doing multiple things, or valuation of donated items, which are generally not considered in the financial cost. So economic cost is broader perspective where you consider everything to cover the program. Second important thing is that we considered the cost from the government provider perspective. Why? Because we did the study assuming that this will be useful for the government. So we considered only those costs that is cost to the government. We never thought about, say, for example, what I said, for the parents, when they bring their kids for vaccination, there are some travel expenses for them, or there are some time cost for the parents. But we did not consider that because we thought that government may not be interested to know that portion. Government will be interested to know how much it is costing me to provide the service. Then in India, the immunization is provided, like the government facility. Um, you have probably seen that these are provided at the facility level. Sorry, if you go to the district hospital or CHC, PHC, any Wednesday, generally any Wednesday, you will see that vaccination is happening there. In some states, it happened on Thursday, but generally Wednesday is for vaccination. It could be on Thursday, and many in other states, it could be other days as well. But it is at the facility level. It happens at the facility level. Also, it happens at the outreach because we need to cater to many children, and everyone will not come to the facility to get themselves vaccinated, like get the child vaccinated. So it could be at the outreach, that is at the villages as well. We considered both facility level and villages. Outreach session, what we call. We considered all activities, but we excluded campaign because campaign is a very different mode of operation. So we excluded the campaign portion, but we only considered all routine immunization service related activities. Next, please. Just to tell you how we calculated the personnel cost, because I'm sure you all know about an A&M. So A&M is basically responsible for conducting the immunization session, either at the facility or at the outreach site. And there are a lot of activities related to immunization, like the conducting the session, then preparing monthly report, then vaccine supply, handling the vaccine and supply, attending training, meeting, preparing microplan, lot of activities. So all these activities, we first identified all the activities related to immunization, and then we interviewed each and every staff to understand from our sample facilities, 255, we asked them, how long did you actually spend to do this activity? So it was not, that's the difference between what we did in the comprehensive multi-year plan costing and here we actually interviewed, but there we assumed that they will approximately spend 6 hours for conducting immunization sessions. But actually we found that it was 3 to 4 hours, not 6 hours. So that's the difference. That's what I said, like what was the difference between that and this study? It was more detail, asking each and every personnel to understand what is the time spent for immunization related activities. Now, why this was required? Because none of these people who work in this activity are 100% for immunization, right? Think of an A&M. She is not 100%. She does immunization, she does family planning, she does several other things. So her time we are interested in immunization. So her time only for immunization was considered. For others also same. We asked, how long did you spend actually for these activities, and then multiplying these by their hourly wage, we calculated the personnel cost for all the activities. Next, please. We also considered the capital cost. Now, capital cost meaning is the building, is the equipment. Actually, definition of capital cost is those which last more than 1 year, whose life year is more than 1 year. So everything is capital cost. So now think of a building, of a CHC building. So CHC building is a big building, and then there is a room, only one room, where immunization sessions happen. And that too, it does not happen 365 days. It happens once a week or twice a week. That means a particular number of days. So to calculate the building cost for immunization, what we need to do is we need to apportion the total cost of the building for immunization. So we took into account the total building area, then the area of immunization and how many days it was conducted there. So, and then apportion the building cost. For equipment also, there are some cold chain. I'm using the word cold chain. Cold chain is a particular activity, cold chain related activity, which mainly involves handling the vaccines and supplies, because someone has to take the responsibility to ensure that the vaccines are taken from district to the CHC to PHC, finally to the sub-center, finally to the session site. Someone is responsible for that. And the vaccines are kept in deep freezers and ILRs, ice line refrigerators, which is called the cold chain room. There is a room, you will see every facility where vaccination happens, I mean, which are cold chain point, of course. But generally in the CHC, you will see that there is a room where these ILRs and deep freezers are kept. So that's a cold chain room. So we have to also figure out how much space the cold chain is taking and how many equipment are there to calculate the capital cost. Next, please. And then there are a whole lot of recurrent cost, which includes vaccine and supplies. So, and then incentives to ASHAs. ASHAs get a lot of incentives for social mobilization and full immunization, ensuring those. And then vaccine transport, there is fuel, there is vehicle maintenance, there is generator use. There are a lot of expenses for different immunization related training, meeting, monitoring, supervision, printing, stationery. But remember, everything is related to immunization. We are not interested in what is happening in the total CHC. We are only considering immunization. And then there is overhead expenses. That is another challenging thing, because electricity is for the whole CHC. It's not for immunization. But the cold chain equipment is actually taking some energy and some electricity. If the building is maintenance is conducted, then the cold chain room is also included in that. The immunization room is also included in that. So everything we considered, we distributed the cost based on different criteria, which is like acceptable criteria. We did that, and then we calculated the recurrent expenses. So that's how we came up with the final cost of the program. Next, please. So this is our final result. So what we are finding here, if you look at the last column, which is the national estimate, we calculated this national estimate. I took it directly from the publication, so it is 2017 US dollar, but you can multiply this by 64 to get the INR. So to reach out to each target children with the vaccine, the government need to spend $28 per target child. So now, and okay, I'm coming to that, but if you can see that there is a difference across the states, it varied a lot. It was the lowest in Bihar, it was $16, and in Kerala, it was $35. But the national average is $28. Similarly for cost per dose and everything. I marked Kerala because I will come back to this, but this is how we get. So to get this number, like what is the cost to reach one target child, this $28, we need to do so many calculations and interviews and everything to come up with this national estimate. Next, please. Now, the interesting point is, what is the use of this? So this $28 multiplied by 26 million is actually giving you the total budget you need for the program. So just to get that number, like what is the budget requirement for the program, we needed the figure cost per target child, which was missing in our country for this program. I mean, I believe it is missing for most of the program, but yeah, I don't know if there is any other, I am not aware of about any other such studies where we have this information, like national representative figure, national estimate of this. So this is the first application that you know that you need $28 to per child to get your child vaccinated, and you have 26 million birth cohort. So you multiply and you get the total amount. Now, when we did the financial projection in 2013, we actually estimated $25. So we actually estimated $3 less than what we found in this study. So that's something what we got. And then of course, it varied across state. So if the states also have some idea like how much do I need to reach to the target children, then they can also figure out their budget properly. So that's first application. Second, of course, there was another next plan, comprehensive multi-year plan, which is 2018 to 22. This is the cover page of the report. And again, I was fortunate that I was given the responsibility to calculate the cost and financial projection again for 18 to 22. And definitely I used this cost estimates, whatever we found in the field, to put into this report so that my results, I can confidently say that whatever results I am saying is robust enough because we got the data from the field and we are using a national representative estimate to come up with this estimate, like the financial projection for this plan. So this is the second use. And another use is, if you remember the part I marked for Kerala, Kerala has the highest cost for per target child. Now, why it is so? Because Kerala is the most developed state. Why Kerala will have such a high cost? When we looked at the indicators, we found that it is because in Kerala, every immunization session is attended by a medical officer also. It's not only the ANM. So every immunization session will have one ANM, one medical officer, plus another person, could be a supervisor or another ANM to support them. So 3 persons are present in each and every immunization session, which is actually increasing their time cost significantly. And that's the result of having higher unit cost for them. When I was presenting these results to them, I was a little worried if they will accept this or not, but they accepted because they said, yes, this is very true that we'll have higher cost, but because we ensure the quality of services. Now, this is another research question whether really the quality improved because of the presence of a medical officer in every immunization session. That's a question of further research, but this is how it happens. But Kerala, from this study report, Kerala can think about whether they want to do anything to decide the efficiency or reduce the cost, whatever, if they feel so. So that is another application of the study. Next, please. At the ground level, so what I did here is we put like number of doses in the horizontal axis, cost per dose in the vertical axis, and all community health center, PHC, CHC, and sub-center results, number of doses and cost per dose are put here. So as you can see, if they provide more number of doses, their cost per dose will decrease naturally. If you are reaching out to many children, your total unit cost will decline. That's very common, like natural trend. Now the point is, what is happening with this red circle CHC? This red circle CHC is providing only like about even less than 1,000 doses, and the cost is like $22, while national estimate of cost per dose was $2. So 2 versus 22, what is happening with this community health center? When I looked into the data, I figured that this community health center is located about 1.5 kilometer away from the district hospital. And in district hospital, immunization sessions happened every day. So parents actually prefer to go to this district hospital rather than coming to the CHC, which does immunization only on Wednesdays. But what happened is this CHC is a cold chain point. So there is a cold chain room, there are all facilities there are staff employed there, they are sitting there for the immunization session, but very few children are coming here. So that increases the cost significantly. Again, I communicated this to the particular district authority to see if he wants to make a decision. And in front of me, actually, he took a decision to change the plan. He started thinking to change the plan here because it is costing him so much. Probably the resources can be better utilized in some other places. So this is a clear like explanation. This can show you, this kind of studies can show you, if you want to increase like individual at the facility level, if you want to improve the efficiency of the facility, if the district or state officials are interested, they can do something with these results. And I have seen, it was very nice to see that the district official actually took decision based on this. Like he was thinking what to do because it has such a high cost. Similarly, this sub-center, another sub-center marked in black, it is also such a high cost because the sub-center caters to the villages where there is a very resistant population. They never allow their children to get vaccinated, and the ANMs was trying her best to get the children vaccinated, but very few children actually were vaccinated during that time, which increased the cost significantly. So these kind of studies also can help you think about like the ground level efficiency, if you want to change anything or if you want to do it better based on the study results. This, of course, these study results were communicated to the national level, to the state level, and to the district level to ensure that they can use the study results. Next, please. Then can I answer this question at the end, please? I think yes, just to continue. So when I presented the study results in different forum, I was asked a question. So when we calculated this cost, these costs were based on the current coverage, immunization coverage of the particular state or district or block or whatever. Now, if you know that even after 35 years of operation of the program, NFHS 4 shows that only 62% of our 26 million is fully vaccinated. It varies across states, of course. It varies from like 19% to 93% maybe. 19% in some places in Arunachal and in some places also in UP, actually it was there. So it's a huge range. Now the question was asked that if the government, which government is actually trying to improve the immunization coverage, how much do they need? It's not like a routine program, right? They just want to push it so that the immunization coverage increases. 62% is a bad percentage. 40% of our children on average is not fully vaccinated, which is not good actually. So we need to push it. So there was a program. I don't know if you have seen there are posters, banners everywhere. Intensified Mission Indradhanush program, which actually the Prime Minister announced to make sure that the country reached at 90% vaccination by 2030. So this is really an intensified push to make sure that that all children are reached, like at least 90%. We cannot think of 100%, but 90% minimum. Now, then again, when you do this kind of push, you need additional resources, you need additional money. But again, there was no information in our country to ensure, to think about like what is the requirement. Again, we conducted another study to calculate this cost. So Mission Indradhanush actually happened in those districts which are very poor in immunization coverage. Say it was in 173 districts and not all, you can see that. And then it happened, like the plan was, it will happen from 7th of October to 14th of October. I'm just giving an example. There was some gap in between, but 7 days, starting from 7th October 2017, and it continues till January 2018. So every month for 7 days, ANMs will visit different temporary vaccination sessions to ensure that she vaccinates all missed out children. So this was a really internship push. Next, please. So the basic, now that how the ANM will know who are the children with missing doses. So there was a head count survey, mostly done by the ASHAs, but also ANMs were also included to make sure that they have a due list with missed children. They know what are the missed children in her area. And then they prepare a micro plan based on that. Like, okay, I have these children here and there and there. In these 7 days, I will be sitting in those areas, in different temporary areas, to ensure that all my missing children are vaccinated. So these are temporary sites. They sat there and did the vaccination. It also included several hard to reach areas. Say, for example, in Assam, there are a lot of riverine islands which are actually inaccessible 6 months. This, starting from October, has the positive thing is that the dry season, it was accessible, and they went to those riverine islands to vaccinate those children. Then they also went to the brick lanes when the workers actually come back with their family, with their kids. So those kids were not vaccinated before, so they actually covered those kids to vaccinate. So they actually reached out to several such hard to reach areas. It was such an intensive push. There was a strong monitoring for each and every session to ensure that the missed children are vaccinated. Then there were a lot of resistant pockets where they don't want to vaccinate the children. So there are a lot of motivation, even from the district official, where ANMs could not work, the block officials went, then the district officials went to ensure that the children is vaccinated. So there was really a huge push to make sure that children are vaccinated. And we tried to calculate the cost of this effort. Next, please. So as I said, this is something extra. This is not like what we do routinely, right? So this is incremental cost. That is, what is the extra cost? And of course, it includes economic cost. And we also focused on financial, because the government may need to know what is the financial cost per child so that they can plan for the future such move. Because if they want to do more kind of intensive movement in future, they can just use this result to figure out how much money or how much resources they will need. So we presented both economic and financial, and again, this is government perspective, of course. Next, please. We were here, I'm not going to the details. So we had, till now, this is the largest in the world, this kind of study. never happened. I mean, to calculate the incremental cost of such a push. We were here, all the dots showing where we collected the data, and we have 40 districts, 91 sub-districts, which is basically blocks, and 289 sub-centers in our sample. Next, please. What we are finding here at the sub-center level, which is actually where the activities happen, it is conducting the session actually is contributing the most of the time spent for the activity. So you can see it ranged from 49% to 70% in different states. That is the time spent for conducting the session. So 7-day session every month, to figure out whether to ensure that the missed children are vaccinated. So you have this number. This is how they spend the time for this activity. And the next activity was, of course, a survey from where they found the missed children. So that also contributed a significant proportion of their time. Next, please. I'm not showing you the results of the study, but what is interesting here is to show you that the previous study, the study I mentioned, Bihar, we are lucky enough that Bihar and Uttar Pradesh were in both of our studies. So we had kind of a baseline cost, what I call is routine immunization, RI cost, which is in the second column. So basically to give a dose, routine immunization dose, it is 92 rupees for Bihar and 101 for Uttar Pradesh. But when you are doing a IMI type program, intensive push, you actually need 333 rupees per dose for Bihar and 243 rupees for UP. So it's a lot of money, economic cost though, a lot of money and other resources you need if you want to push to your immunization coverage at a higher level. And that's very obvious actually. Whatever you reached is reached. Now reaching to the unreached requires a lot more effort, and then you spend a lot of money and resources to do that. But these results will help the government to think if they want to do more. Actually, there is another very important policy implication from this study is that I have shown you that it's 70%, 49 to 70% time was for conducting the session. Now we figured that only on average 2 kids were vaccinated per session, average, per hour. Per hour, 2 kids per session. Now, but the ANM said that she can vaccinate 30 kids per session. In IMI, the ANMs were told to be in the session site for long time, 6 hours on average per day, which is, I think, require thinking from the policy level that if you have so few kids, why the ANMs need to be in the session for so long, because that is the time loss for them, and that is increasing the unit cost of these attempts so much, because they are vaccinating few, but their time cost is so high. So this is another policy implication which we suggested. These results are not publicly available yet. This is just under review now. Next, please. So, this is whatever I talked about is the cost information, how you can use for different policy decisions. Now, another important area is that we do cost effectiveness analysis a lot to find out whether the intervention is, whether the policymakers will take this intervention. Now, so all this cost information actually go to the cost effectiveness analysis as input to the cost effectiveness analysis. Actually, the cost is this cost, which we calculated, and then you can use this for any such calculation. Now, in cost effectiveness studies, what we do is generally we present cost per daily averted, disability adjusted life years, and cost per QALY gain. But But the issue is that for the policymakers, it is often difficult to understand what is DALI or what is QALY. It is not very easy to really understand. I also often struggle to figure out like DALIs and QALYs. I mean, I find it difficult to also understand key how it will be properly used for different policy decisions. It is used till now, but there is another new approach coming up. There are very few work in Indian context, which is on return on investment analysis. Now, what is the difference between these two? First is in cost effectiveness analysis, we take into account the effectiveness in terms of health benefits only. So it is either disability adjusted life years awarded or quality adjusted life year gain. But in return on investment analysis, we go beyond health benefit. If there is any other um, other benefits from an intervention, that is also captured in return on investment analysis. That is another positive thing. So, and in return of an investment analysis, the benefits are actually monetized. That is, you can monetize the benefit and then you present the cost. Cost is already in money form. Your benefits are also in money form. So you just do a benefit cost ratio. Both are in monetary form. And then you just say, if you find that your ratio is more than 1, that means this is a good investment. So this is an analysis which we did for 2 studies, one in immunization, one is mental health. So there was a mental health intervention happened in Gujarat, and we calculated the cost of the intervention, of course, the similar method, and then benefits, all the benefits. So it was like a productivity gain over the year. We took into account that the productivity gain, and then this gain was then monetized. So we have the benefit in monetary term. Then we have healthy life year gain. That life year gain was also monetized. So all the benefits were monetized, and then we have cost, we have benefit, and we got the ratio. Again, as I said, suppose the ratio, benefit cost ratio is 5. That means that if you invest 1 rupee for this intervention, you are getting a return of 5 rupees. So I think it is very easy to understand like the benefit cost ratio in this way in return on investment analysis. I think it is gaining a popularity, and it will be it will be done by several researchers in future, I'm hoping. But none of our results are published yet, but I did 2 of such kind of studies where actually we calculated the return on investment. And suppose you have 2-3 alternatives, like in cost effectiveness analysis also, you have 3 alternatives, and you compare the cost per daily awarded for these alternatives. Here, you will be comparing the benefit cost ratio for the 3 alternatives. So suppose one alternative is giving you the benefit cost ratio 5, another is giving 9, another is giving 13. So your preference is 13 because 1 rupee investment is giving you 13 rupee benefit. So if you can come up with this estimate, I think that is much more interesting. So these are like few new areas which are probably important for the policymakers to think of. This is all from my side. Thank you so much for listening.
Thank you, Dr. Susmita, for the very informative and explanatory session. And definitely, the results and learning can help better planning and future of the programs, making budgets for the states and for the policy decisions. So now what we'll be doing for the next 30 minutes is taking questions, and we open for the questions. So participants can ask their questions in the comment box, and they can directly ask questions to the Dr. Susmita by raising their hands.
Thank you so much, Susmita. So I think one question was already there in the chat box for you from Amey. asking for clarity around the analysis at the CHC level. So do you want to start with that?
Ameya, yeah, so no, if you think of this graph, sorry, so the question is that CHC, so the greatest, so it's the efficiency actually is determined by like number of doses and cost per dose. So the one CHC which I showed you at the top, which I marked actually, this is a CHC which gave lowest number of doses with the highest cost. So this is the most inefficient CHC. So if you look at the graph and look around below $5 and 4,000 doses portion, you will see that most of the facilities are there. So that's the most efficient way of delivering the services looks like, because most of the facilities are operating in that level. So that's the average. But whoever is above, at least in terms of cost, who are above, they are not efficient facilities. I hope this is okay. Let me know if you have a question.
Yeah. I think he said it's fine. I had a question for you, Sushmita. Maybe if you could explain the costing work that you've been doing in the mental health space a little bit more in detail. You talked about the work that you're doing in Gujarat with colleagues from ILS.
Yeah.
How have you been approaching costing in mental health? Are there any major differences with, say, the work you described for vaccination, and how in the mental health space, you've been working with local health systems as well as research teams, and any challenges that you've had with that?
Yeah, so no, there are no differences in terms of like accessing data, or because if you remember, right, that we did another study which is Quality Rights Gujarat, which is also a mental health work, and it was in different districts of Gujarat, where we actually calculated the cost from the provider perspective. We calculated the cost per bed day, cost per outpatient visit for mental health in different hospitals. And we also calculated the cost for the Quality Rights Gujarat, the whole intervention. So there were no such specific the same challenges everywhere, because getting this kind of data is of course a challenge, because you need very detailed data from the health facilities. So often that is a challenge, because you need to spend a lot of time doing that. But otherwise things are okay. For Atmiyata, what we did, because there is a local team there who were collecting the data. So they collected data on different scales, and along with that, they also collected the economic data. So they were trained on the economic questionnaire, and then they collected the data. So basically in Atmiyata, we did costing of more costing in terms of, when I say more, it's like both from the provider perspective and from the patient perspective. So the intervention actually was on the persons with common mental disorders. And so when screened, they were asked, they went through an intervention, which are actually counseling sessions by community volunteers. And then there was an evaluation of the program, where different scales were used to understand the changes in their health condition as well as economic condition. In those questionnaire, also in the economic questionnaire, we tried to understand what was the treatment seeking behavior for them, what was the spending for them for treating common mental health disorders. And of course, when I spoke about the return on investment analysis, these healthcare costs were also taken into account to see whether it improved or increased or decreased over the time. So challenges were the same, as I said, as everywhere in the studies. But but we of course in mental health, we did also patient costing, which we did not do in the previous one. Yeah. Let me know if this answers your question or you have more questions.
That does. I see Gauri has her hand up. Gauri, please go ahead.
Yeah, so thank you, Susmita. That was very interesting. You know, we're all, I think, so I'm a developmental pediatrician. So first of all, the talk was spot on for me, at least. But, you know, as we work in mental health and the cost of mental health, I think what you really described very well was how complicated the whole process is. And we are trying to do a cost effectiveness study on an autism intervention. And it might be quite nice for us just to maybe a smaller team, DC, I think is on the call, just to have a chat with you about what we've designed, you know, just to get your view on the way we are kind of planning this, the assessment. You know, the tool is ready, but we just love to have your ideas on this. I suppose my question really is, it's twofold in a way, and it's kind of maybe topical, and it's probably kind of unfair. But I wanted to know that, you know, first of all, I think immunization, routine immunization rates in India are really very low. I mean, I might have missed what you said, but in my understanding, it's at 65%. But, you know, we are very good at this kind of campaign mode of things in India. And I could see that the cost is, you know, exponentially higher when we try to do that with, say, Indradhanush. And I'm wondering whether, you know, in the kind of work that you've been doing, you've looked at the idea of behavior change, because you really want to change behavior of families to accept and to understand the importance of immunization and then embrace it. So is that something at all that the system tries to, is trying at the same time? Because, you know, we can spend all this effort, you know, pulse polio, Indradhanush, but at the end of the day, you know, our routine immunization rates are really, really low. So let me just, that's one part of the question. And I suppose the unfair part of the question is, how ready are we to immunize for COVID? Which you can choose not to answer.
Thanks for your question. Yeah, so regarding the cost effectiveness study which you are doing, I'll be happy to discuss with you regarding the tool and the team. I'll be happy to look and discuss, and that's okay. And second thing is behavior change. Yeah, I don't think we are doing much on that ground. I mean, I totally agree with you that this kind of program, like Intensified mission in the Dhanush type of program, is not very helpful to sustain the improvement in immunization coverage. Because we asked this question, as part of this study also, we asked them whether they felt that it is required. So in some areas, they said it is required, which is kind of seasonal areas, because otherwise they can't reach there. But otherwise, they said it would be much better if you put similar kind of effort in routine immunization, you know, like similar kind of monitoring, similar kind of supervision, so that actually routine immunization gets boosted up to get the, like, what we did in IMI was to convince people in any way so that they can just get the vaccine. So why don't we do this in routine? If we can do this in routine, this kind of monitoring, supervision, and like communication to the community, then probably our immunization coverage will improve, and we really don't need IMI type program, which is so costly. And we have another result coming up, which shows that actually the effect of this program also did not sustain long. The immunization coverage improved initially, but it did not sustain. And in our study, in the costing part also, we have a couple of ways to look at it, and it supports that it did not sustain actually. So yeah, I totally agree with you.
And so Susmita, let me come in here, you know, because I found that graph very interesting, you know, when you were talking about it, and how when you identified that particular sub-center, it was open only for one day and everybody is going to the district. And for me, and you know, for us working in Sangath, where we are really looking at accessibility, and we're talking about, you know, how do we take treatments to communities? For me, the solution would have been to ramp up at the sub-center so you had 7 days a week there, because sub-centers are cheaper to run than a district hospital. And so for me, I just found that a very interesting take, that actually what you implied was that the sub-center was then closed down. So, so I found that kind of a strange solution in some ways, because, for me, the closer a service is, particularly a health service, the more uptake it has. Now, I don't know, maybe it was a very small population, so I don't know the details, but it just seemed that, if we want families to take on any service, and, immunization is probably the most basic of them, unless it's accessible to families, families are not interested. I know there is a whole, there are resistant districts like you describe, and I know the problems in resistant districts. But, it's accessibility. So would it not be better to have vans that go to the kiln, or to go to, building sites and do these kind of mop-ups? So that's for me, which are supervised by a sub-center or a CHC. But, anyway, these are just thoughts which I'm throwing out there.
Yeah, so basically, so that was a CHC which I was talking about. And the CHC, so what happened is the CHC and district hospital was just 1.5 kilometers away. Right. So it was, so it was not very far for the other people to go. And it's in the kind of a main city. So they could easily go to the district hospital. And in district hospital, every day immunization is happening. So they found it very easy to take their kids there, because they know that whenever I go, I will get my child vaccinated. But in case of CHC, they are doing only in Wednesday. So that was the issue actually in this case. So actually, I did not suggest anything to them, but it was their decision.
No, I understand.
Yeah. So it was like the district was thinking what to do. Like, as you said, I don't know, I did not follow up after that, but I have seen that they are thinking what to do with that CHC and how to improve the immunization there. Because the setup is there, the cold chain is there and everything is there, but only that the children are not coming there. Yeah. And regarding your question on COVID vaccine, there are a lot of discussion going on. Nothing, there is no concrete answer yet what is going to happen, because none of us actually know this. So I suppose
my question really, it doesn't require an answer in some ways. But it's just that I can see we are not bad at campaign mode things in this country. I think what is problematic in terms of the way we function in health is the ability to deliver routine well. Yes. And in some ways, the field that we work in Sangath, which is early child development, disability and mental health, what we need to deliver is routine care. So, that's just really for the rest of. Yeah. And I think that's where we've got to, and I think what you described is really important, is the idea of how do we maintain supervision and monitoring so that, services are well provided.
Yeah.
Thanks a lot. Thank you.
Yeah, that's exactly what the officials told us, that the type of supervision monitoring we did during IMI, why can't we do this in routine? If we do this in this kind of intense monitoring supervision in our routine, then it will improve. The situation will definitely improve. We don't need any IMI. That's what they said actually. So basically it's the decision to ensure that this improves so that, routine services are better now.
So there is one more question from Hari Ketan. While doing cost-effective analysis in the studies in mental health, are there any specific considerations to be taken?
So, not really. I just want to understand what you mean by specific considerations, because the theory is similar for all types of studies, so it's same. But if you can specify what you mean by specific consideration, then there is nothing specific, no specific consideration for mental health. It's the similar. But if you can just tell me a little more.
Yeah, Hari Ketan, do you want to tell about what? consideration you want to make?
Yes, ma'am. Thank you for this wonderful talk. I wanted to ask, in terms of calculating disability adjusted life years in the Indian context, if are you using numbers from other countries, or is that can we go about in the Indian context differently?
So it depends. If for your condition, if you are getting the disability weights from the global burden of disease or the state burden, or the India specific results, it all depends, because if you have the disability weights available for the country, then you use that. But if you don't have that, then you have to use the global disability weights. So that's the only point here. But from the state burden of disease, if you can come up with this, you can do that. You should use the country specific. But if you don't have, then there is no choice actually.
Thank you, Dr. Sushmita. There's one more question, like from Akrushi. She says that can you please show your views on Ayushman Bharat's economic perspective? Mm. Could you please spread your thoughts
Yes,
on?
yeah, there are discussions, and there are actually there are discussion going on to evaluate the program. Uh, some of my colleagues are actually trying to do the economic. I mean, they just want to uh, do the economic analysis of this, but I'm not aware that something have happened yet, but definitely there are thoughts going on to do the economic analysis of this, like how we can do this, and I mean how we can do this, and what was the impact of this. So there are thoughts going on, but nothing specific. At least I'm not doing anything on this. But it would be good to see actually. There are a couple of things which are interesting to see. One is Ayushman Bharat. Some of my, as I said, some of my colleagues are thinking, and then there is another thing is the wellness center which are there, and the effectiveness of those centers. Actually, there are some thoughts going on how to do that analysis as well. So this is the plan.
There's one more.
Qualitative, yeah, I can see that qualitative research in health economics. Yeah, often see when we did this study, both of the studies, what I was just discussing, like like the officials told us that if you increase this supervision and monitoring, then it will be RI will be improved, and we don't need IMI. So this is basically a qualitative data. We have this data to explain the situation. We really don't do a proper qualitative study within the health economics. We generally don't do, but I felt that some of my data actually is qualitative, and it helps me explaining the things better. Like whatever I explained about that CHC, about the subcenter, and about IMI is not really quantitative, right? That's what I found during interview, and I'm just telling you the story. So these are all qualitative, but as I said, it's not proper qualitative study as we do, but this qualitative information are very important to give the detailed description to the policymaker, saying that what I have another good qualitative example from this work from the IMI one, because ANMs, several ANMs actually told me that when they did the IMI sessions, because these are, if you remember, these are temporary sessions, they were sitting there. and they did not get the proper infrastructure there, because in their routine places they have their table chair organized, right, and they have some toilet facilities available nearby somewhere. But when they are in the temporary sessions, they did not even get, some of them did not even get a chair or table from anywhere, and they were just sitting on the culvert, they told me. And so what I suggested to the government, that when you do this kind of thing, please ensure that at least the minimum infrastructure is available with them. And when an ANM is in the session site for 6 hours, 7 hours, toilet facility should be available somewhere nearby. But this was also not available. Many ANMs told me that there was no facilities available. So these are very much qualitative data, but it really helped me to give suggestion to the, in the report I wrote all this, that the ANMs told me this, and we have to make sure that when we did this kind of, we also ensure that ANMs are getting minimum infrastructure. So it is absolutely required, but as I said, it's not proper qualitative research.
So, Sushmita, maybe following up on a couple of things. One is, there is this whole push to get more and more contracting done, which is to say that you don't take full-time health professionals, you take them on contract, because I guess it's cheaper to do it. Also, you don't need to pay for social benefits, pension, etc. But it is not really strengthening the health system. So while it might be cheaper to do one thing, how do we bring in the longer-term perspective around health system strengthening and resilience as compared to short-term economic benefits of going with contracting mechanisms? So maybe can you speak to that? How does the field of health economics deal with that question, longer term versus short term benefits?
This is an interesting question, but I never looked at this perspective. Um, I, I I definitely felt that, because as you said, it's very true that it's a very, like, the example is the ANM herself, like a permanent ANM and a contractual ANM doing almost similar work, but they get like 2 times more than the contractual ANM. So I have seen that, but I'm not sure if there is any work on this, actually looking at the long-term and short-term benefit of this thing. I'm not aware about this, actually. But this is interesting. Sorry,
Okay,
I
I think
could
there's
not
one more
answer you.
question.
Yeah.
No, that's okay. I mean, these are thoughts. So, I mean, these are
Yeah.
more for agendas for discussion and also from a longer term
Yeah,
perspective. There's
yeah.
so much we are learning from COVID. I think there's a question on chat around
Yeah,
data.
disability weight. Yeah, I'm seeing that. Yeah, so I used a disability weight only for one of my studies, and that's long back. Actually, I calculated the DALYs based on like patient data, and at that point and it was for different conditions. So I took the data, patient data, like 3,500 patient data from a hospital, and then I tried to calculate the disability DALY for them, because I wanted to calculate the cost per DALY averted in that hospital for a surgical unit. But at that time, of course, I used the global disability weight, because I had so many conditions. So I used the global weights. But one has to be very careful about while using the global weights, because the global weights varies a lot in 2 different versions. So I mean, even my suggestion would be, even if you use global weight, you do a sensitivity analysis using the other year weight. So 2010, and then there is 2004, I believe. These are the weights available for different conditions. So if you use the latest one, you do a sensitivity analysis of the using the other, because your result will change a lot, because we have seen that. Yeah. So yeah, I used at least the global one for my work.
Okay, any more questions from the teams? One of the things I wanted to ask you, Sushmita, is around out-of-pocket expenditure. I mean, a lot of the costing which is done is the formal expenditure by the health system on personnel, on resources, on infrastructure. But we all know that out-of-pocket expenditure is fairly high in India, and that also is a cost of accessing healthcare. So, are there, in policy decisions, have you seen folks think about issues around out-of-pocket expenditure because of stockouts, because of distance, because of challenges in accessing healthcare, and then try to make decisions which can hopefully lessen out-of-pocket expenditure?
Do you mean like the okay, so definitely out of pocket expenditure, if you think of immunization, out of pocket expenditure is not much. But if you think of other health services, say for example, tuberculosis, TB, what again I'm doing now, I'm just giving you an example of the out of pocket expenses. So TB medicine, the drugs is given free of cost from the government, right? But if you look at the patient perspectives, patient actually spend a lot of money, even though we in the global target and in India target that we think that there will be no catastrophe, no out of pocket expenses for the TB patient, and we try a lot of things for that. But when we look at the data, because I am currently working on this only, we are following up about 2,500 TB patient. Over every patient will be followed up over a year or so or more to find out their out-of-pocket expenses, and it's massive. And actually, the Central TB Division of the Ministry is interested to know this because they thought you probably know this, that the government already provides 500 rupees per month to all TB patients as nutritional support. And here also there is a huge policy implication from where I started this work, because I have seen that giving this direct benefit transfer, this 500 rupees to every TB patient every month for 6 months, is taking up 40% of the government's budget for the first year. So I was wondering whether the TB patient, we know that TB is mainly associated with poverty, but does this really helping the TB patient? Like you are spending 40% of your budget on giving them the DBT, the direct benefit transfer, which is 500 rupees per month. But is it really helping them? So that was the starting point for my work, current work. And I really wanted to see where the TB patients are spending, where they actually need the help for the government. And why I did this, because the government is planning to reimburse some more expenditure. And I said, okay, please allow me to do this work, because I first want to ensure where they need the money, when they need the money. Is it during the treatment, or is this before treatment, or is this after treatment, and for what? So they have already started giving 500, so nothing can be done on that. But my study will tell them how much is the money, out of pocket money spent, where it was spent, when it was spent, and then they can take more decisions, like how they want to help them in future. Is this the answer of your question?
Yeah, thank you. No, that's useful. Thanks a lot.
Yeah, so is there any question? So participant can ask the question directly to Dr. Susmita, or we can just wrap up our today's session. Yeah. So thank you, Dr. Susmita, to coming here. Your session was very impactful and informative. Definitely, it will help to us a lot. I'm just thankful to you and our participant from the Sangath Bhopal team. Our next webinar will be on the research seminar in January, because December is packed for the Christmas. Thank you so much. Thank you.
Thank you so much. Thank you. Bye.
Thank you, Sushmita. Thank you on behalf of Sangath. Very, very
Thank you
interesting
so
work.
much.
Thanks. Bye bye.
Thank you. Bye.
Thank you.